To send you information on this course. You can scan that QR code and it has all my personal stuff. They'll give you a little yellow label and all my contact, and then if you like add me on your contacts, has my numbers, email, YouTube channel, everything. I'm John Canelopoulos. Fortunately, Ed had to fly back this morning. He had a family emergency, and Greg had a medical emergency that he flew back to New York yesterday, so you're stuck with me today. I have opted to present to you, starting in just a few seconds, introduction on topography guided concepts, and then I will, since I have to go to another course at 12, I will run a video of the same course that I gave at in Washington at Asperis last April. So it'll be the course description, etc. The only thing you may not hear of that recording is a few questions from the audience, but I usually repeat them when I answer them in the course. So if everybody's done with this, I'll take it down, or should I leave it on for a few more seconds? Okay. Well, I'm thankful that you're here. I know it's a beautiful day. Everybody's going back home, and of those who don't, strolling in Chicago this Monday morning is a beautiful opportunity as well. All right, so I'm John Canelopoulos. I am based in Athens, Greece, and I'm part-time in New York City as well. Okay, so this is project. I think that's good. And I do have financial disclosures to make for topography guided treatments, as I had been for many years a consultant for Wavelight at first. Alcon, who acquired Wavelight, the German company who designs most of the lasers that I have been working with. I will try and stay within being politically correct as far as customization, and the fact that having worked with all platforms, the Schwinn platform, which is very popular outside the US, I know Ed Manch from Stanford is the guru in the US on the J&J platform. I cannot fill his shoes on the amazing wavefront stuff that this platform does, and I know that it will start doing topography guided treatments as well. So I'll try and walk you through a little bit on why is it that we're interested in topography guided treatments. This segment will be in normal eyes. Obviously, topography guided, the mainstay of custom treatments today was designed to treat irregular eyes, not regular eyes. So it appeared in Europe in 2003 as a tool to fix scarred corneas, botched up ablations, old arcade patients, and it was in 2013 that it became approved in the US as a treatment for virgin myopic eyes. Commercially, for Alcon is known as Contura. It has its fans in this country for people who use the Alcon platform. So the issue with laser today is that there is no issue. Laser surgery today is the safest, probably one of the safest in medicine, and the safest it has ever been. So any laser platform can give outstanding results. We've learned how to measure patients, we've learned how to use cornea diagnostics and avoid some of the tricky corneas that we had treated in the past. We just finished a course with Steve Kleiss and Renato Ambrosio on keratoconus diagnosis. So this discussion here we'll have today has only reasoning if you're looking at more than having a patient not wear their glasses and contact lenses. Because to achieve spectacle and contact lens independency is almost for granted with any laser platform at any practice, anywhere in this country, anywhere in the world. Taken that you will keep certain rules and you will stick to certain protocols, and of course the patient will be compliant with your pre-op and post-op regimen. So this here has significance if you are looking into using a laser procedure to correct myopia and myopic astigmatism, hyperopic treatments are not very popular. I personally perform hyperopic corrections up to +3. And you all want to use that procedure as a means to gain more. What is it that you can gain more from a laser procedure? In simple terms, there is technology that can help you through lasering the cornea line up the eye optics. So imagine the eye as an old style camera that has 2 lenses instead of 1. The crystalline lens, if the patient is phakic, or the pseudophakic lens, and the cornea. So in nature, this system is relatively well lined up. You'd be surprised though how many small deviations in this alignment exist. Now, these are not that important because people can function all their life with excellent vision without ever having any complaints. But if you do have the technology and you have the drive within you to explore the possibilities of this technology, you can use a simple -3, -4 method correction to improve the optics of this particular eye for the rest of the life of this patient. So a 25-year-old gentleman or a 25-year-old lady who has LASIK or PRK today may benefit from this if 20, 40 years down the line they undergo with today's standards cataract surgery, because their cornea optics will be lined up to the line of sight. Now let's go to specifics. How would I measure such a benefit? I will not be able to measure it if I have my optotype in the office that stops at 20/20, because I can get 20/20 with almost everything. With a wafer optimized procedure that most lasers offer today, you're at 20/20 already, so there's no reason to going through all this process. But if I'm looking into lines of vision gain, this is a parameter that's very well studied in refractive surgery studies, because in line vision gain, we're comparing best corrected acuity before to uncorrected acuity after. So if we have gained 1 line of vision, that means the patient is seeing better than they were ever able to see before. So that is an objective improvement in their visual function. Contrast sensitivity is another objective way to measure improvement in the optical function. You can see here the red line is the pre-op, the blue line is the post-op. We were not able to obtain this as a result for many years with laser vision correction. It was usually the opposite. The before was better and the after was outside the gray, below the gray, meaning poor visual quality with smaller ablations, non-aspheric ablations, etc., etc. So what does improving eye optics means? We're seeing here an example of what we will all agree is a perfect topography. Very symmetric astigmatism, correct? Everything looks fine here. The only difference here, I don't know if I have a mouse, is that this regular astigmatism, if there is angle kappa, and there is an angle kappa, because see the Myers of the placido disc here center at the first Purkinje image, so theoretically at the vertex of the cornea, so theoretically at the line of sight, that is not at the center for this patient of the pupil. So this particular eye, if the patient is fixating at the topographer center, has angle kappa. Do we all know what angle kappa is? And the angle kappa in this particular topographer is shown in these numbers here as an XY deviation. If I can read these numbers, on the x-axis is 250 microns, 0.25 millimeters, and on the vertical y-axis, 270 microns. That's a significant deviation. So for this patient, this regular astigmatism on their cornea is seen by the patient eccentrically, 250 microns on the side and 270 microns higher. So how does an astigmatic cornea, an astigmatic lens, work? Pick one of your trial frame lenses with, this is 2 diopter astigmatic, 2 diopters of astigmatism, and put it in front of your eye. Look at your Snellen chart in your exam room and try and move that lens a little bit. It will distort your vision because it will act as a prism. So this patient's refraction, by default, has accommodated this optical irregularity, which everybody would swear this is a perfectly regular cornea. So this is why the manifest refraction on this patient may show it different in amount and axis cylinder. Because the patient objectively, subjectively, but they will try and improve what they're seeing by adding virtual astigmatism in the refraction that will compensate for this decentration. If you've understood this, I need not to speak anymore about customized ablation. This is the core of customized ablations in virgin eyes. This is it. Because most of the optical aberrations of a normal human eye are on the cornea. It's very unusual that a healthy 25, 35, 45-year-old myope will have aberrations elsewhere. So most wafer parameters rather, measure cornea aberrations. And when you fix these, you improve, besides the lower aberrations, which is myopia and astigmatism, also the higher aberrations. You can, and we all do it, and 95% of surgeons in the planet will treat this eye centered on the vertex with a manifest refraction. And that's fine. If the patient is seeing with a manifest refraction 20/20, after the laser, they will see 20/20. But this irregularity, this prismatic effect of the cornea will remain. And it will come again on the desktop when this patient has cataract surgery. Because the lens that will go in will center in the capsule bag, ideally. And if we're using a toric lens, the toricity of that lens will be based on the topographic values of this cornea, which is slightly decentered. So then, we may lose a line of vision, or we may lose quality of vision. So this is the core concept, and I'll show you a few examples. This is an extreme example. This is not your everyday patient. And of course, this talk and the video from Aspers and the video from today, I will post on our YouTube channel. It's Laser Vision GR, our YouTube channel. We posted all the videos of all the presentations over the last 10 years, and you're welcome to see them. So I'm going to try and explain the same thing here. Again, the patient we saw, regular astigmatism, the refraction, as you can see up here, is half a diopter of 45 degrees. And it's shown here with the red axis on the plus axis. So is this at any way near the cornea topography? No. Why? Why is it that the patient in manifest refraction chooses a different axis and different amount of astigmatism? The topographer measures 1.1 diopter at 0 degrees. So this is an exact width of rule astigmatism, right at 90 degrees. Why? Because of what I've circled here. What I've circled here is that we have a 30 micron deviation on the x-axis, not much, but we have a 280 micron deviation on the vertical axis, on the y-axis. So this makes this cornea act like a prism. And when you transfer the data of this cornea in your topography guided platform, this is available everywhere in the world since 2003, in the US since 2013 by ALCA. They were the first to bring in. Many companies will have topo guided options soon in the US. The topographer, if I zero my refraction desired, will do this. Why will it treat this irregular ablation before any myopia and astigmatism? Because it's going to try and make this quote-unquote symmetric cornea symmetric to the vertex. So as you're seeing here, besides a little bit of trifle, it's going to try and treat some oblique coma. And the oblique coma, see, it's hotter, the ablation is hotter here than here. The oblique coma that it will treat matches exactly the minus cylindrical axis that the patient chooses. So there's no mystery in medicine. Now, you may choose to treat this patient with minus 6.5, minus half at 45 degrees, wafer and optimized. That's fine. Patient will see 20/20. But if you treat this patient topography guided, your topographer will fix that. So make the cornea symmetric to the vertex. So then your manifest refraction of minus half of 45 degrees will be wrong. Because what will happen is it will move, quote unquote, this regular astigmatism right on the vertex of the patient. So the real astigmatism of the patient will be one diopter at 90 degrees, in laser language, one diopter at 180 degrees, or 0. Now this simple principle eludes 99% of surgeons globally. They cannot understand it. I've been in fights with the greats, such as Noel Alpens, who recommends we do a blend of the two cylinders. So we take the topographic, we take the manifest, we put them together, we do a vector that has both. That's an interesting approach. Here we're doing something different. Here we're asking the topographer to reshape the cornea to the cornea vertex. So we're changing the cornea. We're making it very symmetric to the cornea vertex. Of course, before you do this, because we're seeing a placido disc topographer, you have to validate these data with a pentacam that has total cornea data as well. Because maybe we have posterior cornea astigmatism that indeed makes this refraction correct. So I'm using the topographer, I'm reshaping the cornea, so now I have to pay more attention to what the topographer is measuring as true cornea astigmatism if I want to correct it. So this is where the TMR concept came. And all this stuff didn't pop out of my brain, it came from treating irregular eyes. When you treat irregular eyes, and we've presented this meeting as back as 2004, I'm quite old, published in 05, how to enlarge optical zones, all this work done in Europe because this was not FDA approved at the time, how to treat keratoconus eye, you can see here, how to treat a cornea scarred eye from a herpetic infection, no, this was an infection from a contact lens, that the scar has flattened the cornea, and if the patient is contact lens intolerant, I was trained, you have to do a transplant. So now with this technology, you were able to reshape the cornea, and when you do this type of work, and we've published over 70 papers treating keratoconus therapeutically with reshaping the cornea with laser, then you learn that the refraction of the patient is an attempt to find the manifest refraction that can help it manifest, navigate rather, through this multifocal cornea. So a little bit of that happens in normal eyes as well. So it's the same concept, treating irregular eyes applied to regular eyes. Wavefront treatment. So this is another example of how the manifest is 160 degrees, half a diopter. The topographic is at 18 degrees. We are 28 degrees off here, and much more astigmatism, which is important only if I do topoguided. If I do topoguided, it's important because I will reshape this cornea. And you see here, the topographer will treat mainly a horizontal cone. It's going to be hotter inferior to the center, colder superior. So this little arc up here by the laser is meant to make this area steeper, and this arc here is meant to make this central part of the cornea flatter, so it can reshape this regular astigmatism that's a little bit irregular because of angle kappa. Does everybody understand this? So this is the concept of customized ablation. Either if you approach it with topography or you approach it with wavefront. Topography for me is more honest because it's more reproducible, that these devices need 6 to 10 measurements that are absolutely similar to each other. We reported our TMR, which is, if you're doing topography guided, use the topographic amount of cylinder and topographic amount of astigmatism and adjust accordingly your spherical equivalent. And we even studied going 50% TMR, so going halfway the different in axis and different in amount of astigmatism in topography guided treatments. And we showed that even if you go halfway TMR, you're getting 80% of the benefit. What is the benefit? Lines of vision gained. This is, we published our first TMR concept in 2016, and this study comparing 50% TMR to 100% TMR is under review. So closing My experience in topographic guided concepts is ray tracing, which is currently an FDA trial. It's been CE marked in Europe since 2019, which came to validate the Canelopoulos craziness, because it does all what I described to you automatically at a press of a button. It uses a commercially available device. This is a device that Oculus has brought out. It's called the Pentacam HR AXL Wave. So it does three things: interferometry, Hartmann-Chack wavefront, and a fantastic Pentacam. Wavelight took this device, they baptized it sitemap, and they use now the data from the device, the interferometry data seen here, to design a 3D model of each eye evaluated. So we're not using the Goldstrand eye anymore that all laser treatments use as a standard, changed only by the actual length or the amount of myopia. We're using an avatar eye for each eye of each patient. And then it uses 2,000 rays from the Seinfeld imaging, the Pentacam, towards the eye into the anterior surface of the lens, and 2,000 rays from the retina using the Hartmann-Chack wavefront, all the way from the retina to the anterior surface of the lens, to create a model of the low order and high order aberrations. Well, you guessed it. The treatment that it wants to do, set at 0, is the topography guided fix we saw before in 99% of the patients. The benefit is you don't have to do the math and adjust your spherical equivalent, because the device does it for you. And it takes seconds to do. And it's foolproof. So I don't know if this is going to be the new way that we treat. It's a combination of a wavefront and a topography guided treatment, but it does validate all the work that we've done. So I don't feel that weird or being so a little bit exotic and a little bit underground in my thinking, because this concept came to validate all the work that we've done the last 10 years. And we've done studies where we did the Innovise, this is the commercial name by Alcon, they may change it. Let's use the term ray tracing. It's an old concept. It used to be done manually back in 2008, published in 2008 as a manual ray tracing process. So somebody had to go to a computer and spend 5 hours to create a treatment algorithm for each eye. And this is done now automatically by the software. So the software is automated. It takes these data and it applies them. It gives me higher order aberrations and the lower aberrations. They're all very similar for it to go ahead. So the numbers of the refraction are on the top left of that summary map. The other very important step, besides the ray tracing, is it calculates tilt between the cornea and the lens. The cornea and the lens may have tilt between them that the topographer is not seeing. The topographer is seeing the cornea as a single refractive object. Ray tracing sees also potential tilt, the two red lines there between the cornea and the lenticular system. So it does correct that as well. So this is an example before, and the proof of concept. This is what the laser is trying to do. You can see at the bottom, set at 0, and this reminds us of our topography guided fix we looked at before in TMR, but it's done automatically. And the case on the right, 3 months later, with proof of concept measured by the device at 0, and very low high order aberrations. So this concept actually works. There's another case, I added an extra tool. Here you're seeing on the bottom right, the topography guided fix. On the bottom left, the ray tracing fix. What's the difference between the two? The difference between the two is the ray tracing fix is hotter on the left. Why? Because it's going to also correct tilt between the cornea and the lens of the eye. This is magnificent. This would have passed, a patient could have lived all their life with that tilt. They would have seen good, but now they can see 20/10. And it's all automated. It's within your procedure. You don't have to do anything more than do a good LASIK flap, have the laser do the work, and give this gift to patients. And it's automated. You don't have to do all the thinking we do, all the work that we do. The necessary step, and we talked about this in the previous course on cornea diagnostics, is that the top right picture, you need to have epithelial mapping confirm that this eye surface is naive. It's a normal surface. So with this particular device, the OptiView device, it's now the Visionics device, a normal epithelium is green. And it's amazing, we've published on this, we published most of the initial literature, how to use anterior segment OCT to map epithelium back in 2008. All patients of all age, of all races, everywhere in the world have the same epithelial thickness with this device, 51, 52 microns throughout the cornea. So the epithelial thickness of the cornea is kind of like the core temperature of our body, 36.8. It's very sensitive. If it's off, you know there's something wrong. You don't know what it is, but it's very sensitive in picking up changes. And also remember, cornea is the only part of our body that changes less than 1% in our lifespan. From the moment we're born till everybody says farewell, our cornea has changed just 1%. Nothing else in the human body is so stable. That's why these interventions may actually have a lot of merit if you like to go beyond 2020 and you like to offer patients, and of course your patients understand this and are willing to put in the expense that this technology and this work has. In my particular practice, we don't charge extra for this. We try and explain this to patients, and this is our go-to way. And that's the concept of TMR. These are, of ray tracing. These are the data. I showed you those before. Fantastic astigmatic correction as expected. A lot of lines of vision gained. Almost 82% of the eyes gain 1 line of vision. 20% of eyes gain 2 lines of vision. These are outstanding data. Conscious sensitivity better post-op than pre-op. And on the NIE subjective questionnaire, in the key elements of visual functions, patients aced it as far as these key questions. And I will close with how this makes sense, and we published on this in treating keratoconus. I don't know if you're familiar with our Athens protocol, which is using a topography-guided therapeutic reshaping of the cornea with cross-linking to improve visual function in keratoconic eyes and of course stabilize them. The advantage with ray tracing in those eyes that you can scan is that ray tracing reads a cone as a tilted cornea. So look at the cone on the left. The ray tracing technology will view this cornea as a cornea that's its top is tilted towards the back. So what's the benefit of this? It will laser less on the cone and more on the far upper periphery to reshape the cornea, thus removing less at what we're all concerned, the thinnest part of the cornea. So this was the first publication, the Journal of Cornea, using ray tracing in keratoconic eyes to have our Athens protocol, which is internationally the top choice in patients who are contact lens intolerant with keratoconus. Most surgeons use a type of PRK and cross-linking. They don't all call it Athens protocol. That's fine. No hard feelings there. But we're very proud that our concept from 2004 has become the standard of care globally. Of course, always with caution to not remove too much tissue and to select patients carefully and, of course, explain to patients. So this is the part that I had. I'm going to go on the video. I will let this guy run. Unfortunately, I will have to go on to my other course. This will complete the course here, and this will go more into detail how to treat irregular eyes, et cetera, et cetera. If all of you have my data, I'm available to send me a topography, a question. It would be really my pleasure. Thank you so much for coming. I apologize for Ed had an emergency with his daughter, and Greg we had a patient in Europe that he had to attend. And thanks so much for coming. I really appreciate you being here and following us. So let's look here at the Topography was designed in Europe initially to be able to treat, to fix sick eyes. So let's look